Okay. Hello, good evening. Today we'll continue our discussion about Fawzia sheet 1. We finished half the sheet yesterday, and today we'll continue the rest of the sheet. As we used to, everyone will take 10 questions and so on. Okay, let's start with Dr. Amina. Please open your mic and start, please.
Okay, good evening, everyone. A 78-year-old woman with emphysema receiving 28% of oxygen by mask has the following blood gas results. The most likely interpretation is, okay, so the pH is acidotic and the oxygen is low, and the carbon dioxide is high, so it's acidotic as well. The bicarbonate is high, and that is alkalotic. So we have respiratory acidosis that is partially compensated because the bicarbonate is high, but not high enough to correct the pH. So the answer is C, partially compensated respiratory acidosis.
Perfect, Dr. Amina, perfect. Okay. Another question, what's your impression? What's your impression when did you see the bicarb is 36 in a patient with respiratory acidosis?
It's a chronic condition.
Perfect. Perfect. Chronic condition. When you see bicarb high in a patient with respiratory acidosis, this patient is mostly a COPD patient, most commonly a chronic condition patient. And mostly in our exam, most cases are COPD. Okay, so that we said chronic condition, because if there's an acute condition, maybe this may be apnea or respiratory obstruction or trauma or any object that sudden hemo or pneumothorax, and the patient in respiratory acidosis due to hypercapnia, mostly you'll find the bicarb is normal. Unless you have a chronic condition, you'll find the bicarb is high, and this is 36, and we have normal up 26. So I think this is a chronic condition a long time ago. Okay, thank you, Dr. Amina. Next question, please.
A 2-year-old child is referred because of an impalpable testis in the left scrotum. Which of the following positions describes an ectopic testis? At the deep inguinal ring at the roof.
What is the mean? What is the mean of ectopic?
Testis that is not in its
what is the mean of
outside its
testis?
normal position. Outside of the normal position
outside
that it's supposed
normal
to be.
Trackway.
Yes, track.
Track outside about not its normal position in the scrotum, but it's away or outside its normal position, track or way. Sometimes you find it intra-abdominal at the deep inguinal ring, in the inguinal canal, at the external ring, or at the root of the or the neck of a scrotum, or in the high in the scrotum. So this is the normal testis sites. Undescended testis may be mal-descended or maybe ectopic testis. Ectopic testis, that means that the gubernaculum leads the testis to another way away from the normal track, outside the track. Okay?
Okay.
Okay, continue.
The deep inguinal ring at the root of the penis, at the superficial inguinal ring, in the inguinal canal, in the upper part of the scrotum. So all these are, except B is the ectopic. The rest is the normal tract of the testis.
Okay. Deep ring is right, superficial ring is right, inguinal canal is right, upper part of the scrotum is right. In the exam, you have two things. Sometimes you find it at the root of the penis, and this is the most common one. Okay, and the
perineum.
other sites sometimes you found in the superficial inguinal pouch. Okay, this is the superficial ectopic superficial pouch. Okay, or in the femoral triangle sometimes, or root of the penis. What happens for this test is it go out from the external ring and then go up to the inguinal pouch above the external oblique sheath. Okay?
Okay.
So inguinal, superficial inguinal pouch, most commonly you will have this. Sometimes you have this, or sometimes the femoral triangle. But this is rarely to come. But this is written in the explanation in MRCS. Yeah. Next question.
Okay. A 60-year-old man is found to have a 2 centimeter diameter mass in the upper lobe of his left lung. The lesion is excised, and it is found that the lesion
Hello.
includes connective tissue.
Okay.
What is the most likely diagnosis? Adenoma, carcinoma, chondroma?
You have some bad connection.
Hamartoma, coma, since tissue lung, which is like, it is like a teratoma, but not a teratoma. Yani, I think that is what
Okay,
hamartoma is.
teratoma. Okay, hamartoma is a teratoma.
Okay.
You have 2 centimeters upper lobe of his left hand. Exercise you find that includes connective tissue, mature cartilage, seriated epithelium. So this is teratoma or hamartoma. Okay.
Okay.
This is not adenoma. This is not carcinoma. This is not chondroma. This is not sarcoma. All of these don't have all this mixture of cells. Yes?
Yeah.
Okay. This is a picture. If you want teratoma or hamartoma, he will give you mixed tissue pattern. Yeah.
Okay. A 23-year-old man presents 3 months following extraction of carious teeth with a plaque-like infiltration over the upper jaw with sinus formation. Yellow granules are present in the discharging pus. What is the most likely causative organism? Actinomyces, Aspergillus, Blastomyces, Cryptococcus, Histoplasma. Since this is yellow granules, it's actinomyces.
Actinomyces. Yellow granules or yellow, sometimes he tell you yellow shiny granules sometimes, or something like this. Yellow granules equal in our study in any question equal actinomyces, whatever it is. It is a wound of appendectomy, it is a wound of the nail, it is any wound with yellowish granules, so it is actinomyces.
An 82-year-old man has complete occlusion of his inferior mesenteric artery on angiography, but no symptoms or signs of colonic ischemia. Which of the following arteries is the most likely additional source of blood supply to the territory of the inferior mesenteric artery? Left colic, left gastroepiploic, middle colic, splenic, and superior rectal. The answer is middle colic, which is the branch from the superior mesenteric artery.
Okay, here is he asks you, what is the communicating branch with the branches of the inferior mesenteric artery, which help to cover or to supply the area supplied by the inferior mesenteric artery? This is a very common question, by the way, in the exam, that the middle colic, sometimes he tell you have a cancer patient, have a cancer sigmoid, and the patient went for left hemicolectomy with ligation of the inferior mesenteric artery. What will be the main source of blood supply for the stump? For the stump after operation. The stump, he means this stump, maybe after left hemicolectomy, it will be here, it will be here. He asked about what will be the blood supply for the stump after colectomy. This will be middle colic. Middle colic, as you see here, the middle colic help the inferior mesenteric in supplying the left column, the left flexure and the left column. And it's the main blood supply after left colectomy because we ligate the inferior mesenteric vessel in this operation.
An intravenous drug abuser is having an echocardiogram for suspected endocarditis. Closure of the tricuspid valve occurs at the onset of which phase of the cardiac cycle? Atrial systole, isovolumetric contraction, isovolumetric relaxation, rapid ejection, rapid ventricular filling. The answer is isovolumetric contraction, which is also the wave C.
The most common question about GVP. He asked about closure of tricuspid valve occurs at which phase, which is wave C, which is the isovolumetric contraction. Isovolumetric contraction. This is one of the most common questions. The other question is the absent A wave. Absent A wave.
Atrial fibrillation.
AF. Absent A wave in AF. They always like both these questions. In the GVP, you will find an absent A wave, so it is AF. But what is the closure of tricuspid valve occurs at what stage? It is at the stage of isovolumetric contraction. And by the way, the A wave is the
atrial contraction.
Stage of atrial contraction. This is the most two important common in the exam.
After being stabbed in the left groin, a previously healthy 20-year-old man was admitted to the emergency department. He developed hemorrhagic shock. During resuscitation, 10 units of type O negative red cells and 6 liters of colloid were administered. 24 hours later, he is noted to have severe dyspnea, for which he required intubation and ventilation on the intensive care unit. Which of the following would be the most likely cause of his respiratory insufficiency? ABO, blood incompatibility, adult respiratory distress syndrome, congestive cardiac failure, tension pneumothorax, viral pneumonitis. Since this patient took how many? 10 units of blood, he's likely to have a lung injury that is associated with the blood transfusion, which caused the adult respiratory distress syndrome.
Okay, it is massive transfusion associated lung injury due to massive blood transfusion, and it resembles or it presents with a picture of ARDS, acute respiratory distress syndrome. This is very common. So this is a patient have left groin pain, so has bleeding, admitted to the emergency. He has hemorrhagic shock. He takes 10 units. 10 units means that you give massive blood transfusion. Massive blood transfusion, that means that you give, replace the whole blood in a short time. Sometimes they tell you less than 24 hours. So this patient took 10 units, means this is the whole blood is replaced, O negative red cells and 6 liters of colloid administered 24 hours later. So in a short time, he has replaced the whole blood, and this is what's called transfusion associated lung injury. Okay, and this is the same with adult respiratory distress syndrome, and this is here the most common cause of ARDS. One of them is the transfusion associated lung injury It's a one of them. Okay, continue.
An 80-year-old man with a history of hypertension controlled with thiazide diuretics undergoes transurethral resection of prostate under general anesthesia. The surgery is prolonged, and in the recovery room, he complains of nausea and a headache. He later becomes agitated and confused. Which of the following is most likely diagnosis? Hypercalcemia, hyperuricemia, hypoglycemia, hypokalemia, hyponatremia. Since this patient underwent transurethral resection, the irrigation usually they use the hypotonic solution, glycine, and this causes the hyponatremia in this patient. Symptoms of hyponatremia.
Okay, dilutional hyponatremia.
Yeah.
Okay, so what it is, by the way, and it is not used too much now. They are using hypotonic glycine solution for TURP, for transurethral resection of the prostate. This solution, because the venous dilatation or the venous plexus of the prostate, it is highly absorbed. So if the operation continue more than almost 1 hour, or it is the prostate is big, more than 80 milligram, I think so. What happens that the body absorb all the glycine with hypotonic solution. As you are giving the patient IV post-operative, you are giving the patient IV glucose, 5% dextrose, without giving any saline. The patient will go for dilutional hyponatremia. Dilutional hyponatremia will decrease the tonicity of the blood and will make edema in the brain and lungs and all the body tissue. The most important of them is the lung and the brain. The patient brain edema will make the patient confusion, drowsy, dizzy, lethargy. Edema of the lungs will make the patient difficult breathing up to pulmonary edema, and pulmonary effusion can happen to this patient. Okay, can you read the explanation, please, about these two?
TURP syndrome. Rapid absorption of a large volume irrigation solution can occur 15 minutes after resection or up to 24 hours post-op. Incidence is 1 to 8%. It is characterized by intravascular volume shifts and plasma solute osmolarity effect, circulatory overload, water intoxication, hyponatremia, hypoosmolality, hyperglycinemia, hyperammonemia, hemolysis. TURP syndrome, hyperglycinemia. Glycine, a non-essential amino acid, is an inhibitory neurotransmitter in the spinal cord and retina. It is metabolized in liver by oxidative deamination to ammonia and glycosylic and oxalic acid. When absorbed in large amounts, has direct toxic effect on heart and retina. Manifestation of glycine toxicity: nausea, headache, malaise, weakness, visual disturbances, transient blindness, seizures, encephalopathy.
Okay, the other thing also, not only the osmolarity or the edema that happens, the other thing is the glycine itself is converted by the liver to ammonia, and the ammonia accumulated in the body like the patient with hepatic encephalopathy, and the ammonia is highly toxic to the brain and the neural system for the body. Okay, so in your exam, TURP transurethral resection of the prostate, he want to ask you about hyponatremia. Hyponatremia, TURP syndrome. Next question.
A 35-year-old man is admitted to hospital with vomiting, nausea, and severe headaches. An MRI scan reveals a tumor of the cerebellopontine angle. Which one of the following pairs of cranial nerve is most likely to be compressed by this tumor? Accessory and vagus, facial and vagus, facial and vestibulocochlear, glossopharyngeal and vestibulocochlear, vagus and vestibulocochlear. The answer is 7 and 8, facial and vestibulocochlear.
Okay, in your mind, cerebellopontine angle, because this new question and came about 2-3 times last year. Cerebellopontine angle equals facial and vestibular. 7 and 8. Okay, let's go for this very nice picture. And I want you to know this one. This is the organization of nerves. If you have confused or you have some confusion about 2, 2, 4, 4. This is the plan or how the cranial nerves come from the brain. The first two, olfactory and optic, come from the cerebellar hemisphere. The second two come from the midbrain, oculomotor and trochlear. From the bones come trigeminal, abducent, facial, and vestibulocochlear at the angle, exactly at the cerebellopontine, at the medullopontine angle, or cerebello. By the way, the medulla lies in the hug of cerebellum. So when he tell you cerebellopontine angle equals medullopontine angle, but there is nothing called medullopontine, there is always cerebellopontine angle, okay? So this is the site of the 7th cranial nerve and 8th. So when he tell you, you see the vestibulocochlear and facial, both together are at the angle between the pons and medulla, which is here. Here is the medulla at the hug of cerebellum. So when he tell you a tumor or a mass at cerebellopontine angle, he want to tell you, I want 7 and 8. Because as we know, okay, all the nerves here with the plan 2, 2, 4, 4, 1, 2 from cerebellum, cerebral, midbrain, pons, medulla comes for this till this till the hypoglossal. So 2, 2, 4, 4 is the 12 cranial nerves we know. Very important, this question, and repeated many times. Last question, Dr. Amina.
I can't see it.
Okay, it will come now. Just a minute. Wait, there is, I think, some reconnection happening. Okay, sorry, back again.
Okay.
Okay.
After resection of a distal or a rectal tumor, a patient experiences erectile dysfunction. Which of the following nerves is most likely to have been damaged in surgery? Genitofemoral nerve, lumbosacral plexus, pelvic splanchnic nerve, perineal branch of S4, pudendal nerve. It's the pelvic splanchnic nerves.
Pelvic splanchnic, very common question here, and he changed only in this. After the patient has a rectal tumor, and this is the most common, any tumor dissection in the rectum, or it's the prostate lying in front of the rectum. Any dissection in this area, mostly the patient will have an erectile dysfunction. Most common that the patient have erectile dysfunction post-operative due to injury of the or damage of the pelvic splanchnic plexus. Or sometimes he tell you the hypoglossal plexus. Okay, sometimes he tell you pelvic splanchnic or hypogastric plexus. Okay, so most commonly, okay, pelvic splanching or pelvic hypogastrium.
Okay.
So here, rectal tumor or prostatic resection. Prostatic resection. Both of them have the same results. Okay, next. Okay, thank you. Who's ready, Dr. Hassini? Dr. Hassini.
Yes, sir.
Okay.
Yes.
Continue the next thing.
It's question number 71. A 45-year-old woman presents with pain, swelling, and stiffness affecting all her metacarpophalangeal joints. She has noticed weakness in her grip and her handwriting has changed. She is unable to extend her fingers fully. The index, middle, and ring fingers in both hands show an ulnar deviation. Condition B. Gouty arthritis. C. Osteoarthritis. D. Radial nerve palsy. E. Rheumatoid arthritis. So the ulnar deviation of fingers is a clinical picture of rheumatoid arthritis. So the
yes, one of the picture of
arthritis.
Yes, female patient, middle age, has some swelling, stiffness of the joint, and one of the pathognomonic pictures of rheumatoid arthritis is ulnar deviation. Ulnar deviation. Okay, it doesn't happen in the uterine contraction, in gouty arthritis, osteoarthritis, or radial nerve injury. All of this doesn't make all this picture of ulnar deviation. Okay, radial nerve palsy can make ulnar deviation, but it doesn't give the picture of grip and the swelling and pain and stiffness. It is not the picture of radial nerve injury. Okay, and you don't have any history here for injury.
And also stiffness is also
yes, stiffness as well. Yeah.
So, number 72. A 22-year-old man arrives to the emergency department with sudden breathlessness due to a large pneumothorax. A chest drain is inserted into the fifth left intercostal space in the fifth mid-axillary line. There is hemorrhage into the drainage bottle. Which of the following structures is the most likely cause of his acute hemorrhage? A. Intercostal artery. B. Left pericardiophonic artery. C. Lingula of the lung. D. Right ventricle of the heart. E. Spleen. So it's the approach from the safe triangle in between two ribs. So it most likely causes intercostal artery damage.
A very common question almost in every exam. Okay, next question.
73. 65-year-old woman collapses after a total hip replacement. A pulmonary embolism is suspected. Which of the following electrocardiogram changes would support this diagnosis? A. Dominant R wave in V6. B. Left axis deviation. C. Left bundle branch block. D. ST elevation in V1 to V3. E. T wave inversion in V1 to V3. So the answer is T wave inversion in V1 to V3.
Okay, what is the picture? What is the picture of pulmonary embolism? By the way, if you have any ECG in the exam, most likely you like pulmonary embolism. I'm telling you 100%, but yani, very rare to give to you right bundle branch block, left bundle branch, left lower ischemia, anterior ischemia, inferior ischemia. Very common because it is more for MRCP. He likes you to how to diagnose your surgical related cardiac problem and ECG problem, which is most common, about 80%. We have also the electrolyte disturbance, but about any chest pain or pulmonary embolism, he wants you to know about pulmonary embolism ECG picture, which is simply this one, Q3,
Q3, T3.
T3.
Hello?
Sorry, I just had some noise background. Okay, S1, Q3, Q3. By the way, in my exam, it came for me like this: S wave in lead 1, Q wave in lead 3, and inverted T in lead 3. My exam, I had this complete picture. This was April 2019. I have this complete picture. In this exam, I give you just one of them, which is the inversion of T wave in V1 to V3, or he tell you in V1 or V3. Okay, so if he will give you the full picture, or he will just give you one of them, which is the most important, which is the inverted T wave in lead 3 or in V1 to V3. Plus, so we have two pictures of this question. Clear? In the exam, he likes pulmonary embolism. You should have a question about pulmonary embolism ECG in exam. Again, you should have a question about pulmonary embolism ECG in every exam. Clear?
Yes.
And it is so easy. He will give you the complete picture, or he will give you an inverted T wave in V1 to V3 or in lead 3. Next question.
Question number 74. 40-year-old woman who had the anterior lobe of the pituitary removed because of a tumor without post-operative supplements. Which of the following could occur? A. Failure to produce adequate amounts of thyroxine. B. Fail to produce parathyroid hormone in response to hypocalcemia. C. Failure to secrete catecholamine in response to stress. D. Failure to secrete insulin in hyperglycemia. E. Inability to concentrate urine in response to water deprivation. So, anterior lobe of pituitary secretes mainly FSH, LH, TSH, ACTH, prolactin, and growth hormone. So, according to that, it's the answer A, failure to produce adequate amounts of thyroxine.
Okay. You have just to know an idea about the hormones of the anterior and posterior pituitary. Okay, you have the anterior pituitary, which is the most common. For us as a surgeon, TSH, ACTH, and growth hormone, and the prolactin, plus the feminine hormone, FSH and LH. The posterior, we have only two. One, antidiuretic hormone, which is related to our work in surgery, and the other one is the oxytocin for the lactation. Okay, here is he told you we remove the anterior pituitary. So failure to produce adequate amount of thyroxine, yes, because it's responsible to TSH. If I'm not sure, I just put a mark and then go. Fail to produce parathyroid hormone, no, not related to parathyroid hormone. Failure to secrete catecholamines, no, it depends on ACTH. It depends on the adrenaline, not from here. Failure to secrete insulin, no, it is from the pancreas. And inability to concentrate urine, this depends on the oldest. And even on, yes, an antidiuretic hormone from the posterior pituitary. Okay, so all of them are completely wrong. We only have one, thyroxine. Sometimes before you complete reading the question, you will answer this. Many questions in the exam will be repeated by the same order like this. So when you go to the exam, you can just read this and read this, just mark this and go to the next question. By repetition, by the way, you get used for them. Okay, next question.
75. A 38-year-old man in end-stage renal failure resulting from polycystic kidney disease receives a cadaveric renal transplant. Good renal function is established, but 4 weeks later deteriorates. The serum creatinine rising by 25%. Which of the following processes is most likely to be responsible for his deterioration? A. B-cell mediated rejection. B. Circulating immune complex disease. C. IgG antibody mediated rejection. D. Post-transplant lymphoproliferative disorder. E. T cell mediated rejection. So this is 4 weeks later the surgery. That means it should be acute type of reaction. So
Exactly.
it's T cell mediated rejection.
T cell mediated. Okay. Just not to forget, immediate you have the hyperacute or immediate. This happened at once on table. That means that already preformed antibodies are present in the blood. You get the idea? If the kidney died or rejected after removal of the clamp, that means there is already autoantibody immunity present in the blood, attack the kidney at once. So this is preformed antibodies present in the blood. Okay, but it doesn't happen. It happens within weeks to months or months to years. This will be T cell mediated. T cell mediated rejection, T cell mediated rejection. This happened in the acute or the start of chronic. This is T cell mediated rejection, and very common to ask you about the exam in this. So I want you to know both of them. Hyperacute at once, preformed antibodies. Already there is antibodies in the blood, but if it happened acute or chronic, this will be due to T cell mediated immune response. A very common question in the exam.
Number 76. In order to expose the right axillary artery, a transverse skin incision is typically made below the clavicle from a point just lateral to the sternal end of the clavicle to the delta pectoral groove. Which of the following structures would be encountered in the dissection down to the vessel? A. Lateral thoracic artery. B. Phrenic nerve. C. Suprascapular artery. D. Thoracic duct. E. Thoracoacromial artery. Answer is thoracoacromial artery.
Clavipectoral fascia. Okay. Clavipectoral fascia. Some questions will tell you just below the clavicle. When he want to change in the scenario, but most common scenarios he will tell you during an incision, transverse incision in the clavipectoral fascia. This is the clavipectoral fascia. Will be here like this. Okay. Sometimes they do it for repair or any fracture of the clavicle. You will injury an artery. There is a brisk bleeding will happen. As I say, what do you expect? This will be this branch. Okay, thoracoacromial artery. You don't want the details about this, but thoracoacromial artery is the source of bleeding in the clavipectoral fascia. Don't forget this in the exam. It will come to you, clavipectoral fascia incision, transverse incision, and brisk bleeding. What do you expect the source of bleeding? It will be the thoracoacromial artery. Repeat it again.
Shall I start the next one? Shall I start the next one?
Continue.
Yes. Number 77. A 4-year-old boy presents to the emergency department with a 2-day history of headache, vomiting, and drowsiness. A CT scan reveals dilatation of both his lateral ventricles and his third cerebral ventricle. His fourth ventricle was of normal size. It is suspected that he has an obstruction to his cerebrospinal fluid flow. At which of the following sites is the obstruction most likely to be? A. Cerebral aqueduct of Sylvius. B. Infundibular recess. C. Interventricular foramen of Monroe. Foramen. D. Lateral foramen of the fourth ventricle, which is also foramen of Lasker. E. Median foramen of fourth ventricle, which is foramen of Magenti. The answer is A. Cerebral aqueduct of Sylvius.
Okay, this is the most common place of obstruction here. The most common place of obstruction. Sorry?
Is it the narrowest part of the ventricular system?
Third ventricle and postlateral ventricle. Again, sorry, I couldn't hear you.
Is it the narrowest part of the ventricular system in the brain?
Yes, the narrowest part maybe, but the most common part susceptible for blocked. Very common in the exam. He will not give you all of this. Most commonly here, he will tell you lateral ventricle and third ventricle. So this lateral and this ventricle. So this is the site of obstruction. This will be dilated and this will be dilated. This all will be dilated. Postlateral ventricle and the third ventricle will be dilated. Aqueduct of Sylvius is the most common site of obstruction. And this question is repeated with the same choices and everything, with the same scenario.
Number 78, a 12-year-old boy presents to the emergency department 2 hours after helping his father cut the grass. He complains of rhinorrhea, itchy eyes, sneezing, and a blocked nose. He is apyrexial with a hemoglobin of 12.2 and white cell count of 6.8 with a raised eosinophil count. Chest X-ray is clear. Which immunoglobulin is most likely to cause his reaction? Answer IgA, answer B, IgD, answer C, IgE, answer D, IgG, answer E, IgM. So it's eosinophilia, which is by IgE. Answer C.
This is atopy. This is atopy. He is helping his father in cutting the grass, and then he had sudden allergy, makes him rhinorrhea, itchy eyes, sneezing, blocked nose, and apyrexial. And he is apyrexial, so there is no infection, and he has acute. So what type of reaction, what type of hypersensitivity happens here? This is type 1 hypersensitivity reaction, atopy. Okay, and
Yes.
as we used acid, acti. Acid, acti. Okay, again, acid, anaphylactic, cytotoxic, immune, complex, and delayed. And the type of Ig, egg, T. This is immunoglobulin E, immunoglobulin G, immunoglobulin G, T cell mediated. Delayed is T cell mediated. Okay. Example like TB. This is a delayed hypersensitivity reaction, T cell mediated. This is atopy, acute hypersensitivity reaction. Okay. You have also 2 examples, 2 questions about hypersensitivity reaction. One of them, patient, you make a catheter, urinary catheter for him, and then the patient has swelling, edema of the penis and scrotum, and the patient fainted. This is acute hypersensitivity reaction, immediate hypersensitivity reaction. Yes. You have a patient with a plastic urinary catheter or the Foley catheter. So the okay. Another one, he tell you a nurse started to have some reaction, skin reaction after wearing gloves. What is this? This is delayed contact dermatitis, delayed contact dermatitis, because she is nurse, she is wearing gloves since many years ago and started to have an allergy. So this is a contact dermatitis of the delayed hypersensitivity reaction. Very common question, by the way, these two questions in the exam about the catheter, and he developed edema of the penis, and then the patient started to shock. So this is acute anaphylaxis, type 1 hypersensitivity reaction, but the patient, a nurse developed, he will tell you a nurse developed allergy to gloves. So it is not the first time for her to wear gloves. So this is delayed type of hypersensitivity reaction due to contact dermatitis. This is a question about hypersensitivity reaction in your study. Okay, question 79, please.
79. A 35-year-old woman undergoes gastric bypass surgery for morbid obesity. At a subsequent surgical clinic review, she complains of dizziness, sweating, palpitation, and collapsing episodes after big meals without any vomiting or pain. She is otherwise well and has no medical problems. What is the most likely explanation of her symptoms? Answer A, operative denervation of stomach. B, release of gastrin. C, release of glucagon. D, release of insulin. E, vasovagal syncope. So answer is D, release of insulin.
Because this is
dumping syndrome.
This what?
Late dumping
syndrome.
Late dumping syndrome. This is late dumping, but this one is early dumping. Anyone don't know what is dumping syndrome?
I'm not that familiar with that.
You know.
Sir, I don't know about the dumping syndrome.
Okay, I'll explain. What is dumping syndrome? Dumping syndrome when you are decreasing the size of the stomach. Okay, let's make it clear like this. This is the stomach. Okay, and then the duodenum, then you have the small intestine. Okay. Normally, insulin release when the food passes from here to the duodenum start to feel the amount of glucose, and according to it, the pancreas will start to release insulin. The other thing is the food takes about 4 to 6 hours here, and then slowly the stomach starts to release it to the intestine. So the intestine will see by slowly the how much electrolytes and sodium exactly, especially in this food chyme, and then start to give water and to absorb water according to the amount of salts in the chyme. What happened exactly? What happens that after sleeve gastrectomy or after gastrectomy, we remove mostly this size of the stomach from the stomach and then attach it direct to the intestine by any way, by Roux-en-Y or the stomach. With the sleeve gastrectomy, the stomach will be this size direct with the intestine. So the storage function of the stomach is lost. So any food come here, go directly rapidly to the intestine. Go rapidly to the intestine. What is early dumping? Early dumping is that passage of high amount of hypertonic chyme into the intestine. So the intestine absorbs the whole water from the vessels. Okay, let's make the vessels like this. There is here vessels, and then start to absorb the whole water, will go inside the intestine. So the patient will feel distension, bloating, cramps, abdominal pain. Then the patient may go into diarrhea. And due to absorption of all the extracellular water into the intestine, the patient will have a vasovagal syncope and low blood pressure due to loss of much water inside the GIT tract, and the patient will go for syncope. This is the early dumping. What is the late dumping? This hypertonic chyme also has much amount of glucose, which will make rapid release of insulin, not gradual like the normal stomach, rapid release of large amount of insulin into the blood, which will suddenly lower the blood glucose level, and the patient may go also in hypoglycemic coma because of release of much amount of insulin once. So this is called late dumping because it happens 1 to 2 hours after food. This is early dumping. It happens within 30 minutes after meal. So this is early dumping and this is late dumping. Can you please read the dumping syndrome?
Dumping syndrome, gastroctomized patients, rapid and unregulated dumping of the chyme into the intestine. There are two types. Attacks last about 30 minutes. The first one is early dumping, which is immediately after a meal, associated with hypovolemia due to reduced fluid in blood and hypotension, caused by hyperosmotic chyme entering duodenum. Rapidly extracts large amounts of fluid from the circulation into intestine. The second type is late dumping, which takes 2 hours after a meal. This is due to hypoglycemia, as chyme dumped into intestine results in rapid absorption of glucose into blood and sudden blood hyperglycemia due to hyperglycemia causes rapid increase in insulin that overcorrects and results in hypoglycemia. Symptoms are weakness, dizziness, and sweating after meals.
Okay.
So, in this particular scenario, how do we differentiate it from early dumping as late dumping? Because they have not given
what
any
is early
time
dumping
duration.
here? What is early dumping?
It's
Hypovolemia,
immediately after hypovolemia and
hypotension caused by hyperosmolar chyme rapidly extracts amount of fluid or circulation into the intestine. This patient will be, as I told you, will be represented by abdominal pain, distension,
yes.
Bloating, cramps, diarrhea, and hypovolemia. Okay, the other one is the patient will be presented with hypoglycemia, which will be represented by dizziness, sweating, palpitation, collapsing episode after big meals, without any vomiting or pain.
That's the main point, without any vomiting or pain.
Okay.
Yes.
So this is the point. Okay. And by the way, mostly it will be hypovolemic. Keep it hypovolemic syncope. Not the release of insulin will do this. This is not vasovagal. It will be accurately hypovolemic. Hypovolemic syncope. Okay. So if it is bloating, abdominal distension, and pain and the colic, it will be early due to hypovolemia or rapid absorption of hypertonic chyme. In the late will be due to release of high amount of insulin. Last question, please.
Question number 80. A 56-year-old man with chronic emphysema is on the high dependency unit 10 days after anterior resection. He has developed acute shortness of breath and hypotension. Which of the following landmarks would be the most appropriate to use to obtain a femoral arterial blood gas sample? A point midway between the anterior superior iliac spine and the pubic tubercle. B, a point midway between the anterior superior iliac spine and the pubic symphysis.
Okay, no need for other. No need
yes.
for other. He just confusing by wrong answers. Here is this point is very important. How to differentiate between the site of the internal ring and site of the femoral artery. Most common in the exam, he will ask you about the femoral artery, and less common he will ask you about the internal ring. But simply how you can differentiate between both of them, I'm always tell my candidates that you can make the inguinal family. Okay, what is the inguinal family? External inguinal ring, deep inguinal ring, and the inguinal ligament. This is the inguinal family. Okay, where is the external inguinal ring is the end, and this will make the inguinal canal. Inguinal canal. Okay, start of the inguinal canal is the deep inguinal ring at the mid point of inguinal ligament. Okay, the deep inguinal ring is at the midpoint of one of her family. She is related to the inguinal ligament. It is in the midpoint of inguinal ligament, half an inch above the midpoint of inguinal ligament. What is the external ring? At the end of, or the medial end of the inguinal ligament. This is the family. This is one family. Okay, femoral artery. Femoral artery, where is it? Mid-inguinal point. We have here ring, ligament, and canal. This is one family. So we have the internal ring here at the inguinal ligament, but here it is on the mid-inguinal point, because this inguinal point from the anterior superior iliac spine to the symphysis pubis, not from the anterior superior iliac spine and the inferior superior or the pubic tubercle. This is the inguinal area. So the deep inguinal ring is related to the ligament. The ring is related to the ligament, but the artery is related to the inguinal area at all. So it's in the mid-inguinal area or in the mid-inguinal point. Very important, this question in every exam. Thank you, Dr. Hassi. Who's next? Dr. Alexander, are you ready?
Yes.
Okay. Can you continue, please? Next question. By the way, we want to run a little bit, so we just want to make, even we want to make the videos shorter. I know you can rapid the speed, or you can increase the speed of the Zoom, but as long as I don't want to make every report more than 3 hours, so you can revise it easy. Okay, continue.
A 70-year-old man complains of the persistent numbness since an inguinal hernia repair 1 year previously. The numbness affects at the top of the scrotum, root of the penis, and small area below the medial part of the inguinal ligament. Which nerve is likely to have been damaged? So should I just read the answer?
I think we yes. I want you to know the right answer. Post-inguinal hernia repair. Post-inguinal hernia repair, very common to injury the ilioinguinal nerve, very common. And this one of the cause of some numbness up to when you cut to up to paralytic inguinal hernia, up to direct hernia due to injury of the ilioinguinal nerve. There is no relation to the femoral nerve, genital branch of genitofemoral, iliohypogastric, or medial cutaneous branch of the femoral nerve. No, completely. This is the most common question in the exam, ilioinguinal nerve. Okay.
Okay.
Next question.
A 20-year-old girl has diastolic murmur. It is maximally audible in the second left intercostal space. Pathology of which structure is most likely cause? Aortic valve, ductus arteriosus, mitral valve, pulmonary valve, tricuspid valve. So tricuspid pulmonary valve.
Pulmonary valve. I think we all know about this. Sites of the valves, very important. Second right, second left. Fourth, left parasternal, and fifth mid-clavicular line. This for the mitral area. Right, left parasternal at the fourth space, sometimes in fifth space or the fourth space. This is tricuspid area. On the second right, this will be aortic. On the second left, it will be pulmonary valve. So whatever the murmur, where is the murmur? It will be at the pulmonary valve. Pulmonary valve. This is on the second right, second left intercostal space. Okay, I think this is easy and need you to know it. What is exactly? Sometimes there is a murmur, there's ejection, systolic murmur at the second right intercostal space. What will be?
Aortic.
Aortic. Which type of aortic?
Sorry?
Which type of aortic? If you have in your answer, I told you, you have here ejection, systolic murmur, second right. And in the option, I have two, aortic regurg, and they have aortic stenosis.
Ejection, it's stenosis.
Ejection, it's aortic stenosis, completely right. Aortic ejection, aortic regurg will be, aortic regurg will be in diastolic. لو قال لك diastolic murmur, if he told you diastolic murmur will be regurg. Okay, type. Generally, if he told you systolic murmur, you'll choose stenosis. If he gave you the valve with two options, systolic murmur, you will choose stenosis equals an aortic ejection. Equals ejection. So ejection means systolic murmur at this site. If he told you diastolic murmur, you go direct to choose regurg. Just in case you have a question like this, because you'll have ejection, systolic murmur. If he told you diastolic murmur, means that you have regurg. So systolic stenosis, S, diastolic regurg. diastolic regurg. Okay, as example, if he told you there is a murmur on the left, murmur on the right, left mid clavicular line, fifth intercostal space, a diastolic murmur. What do you expect this to be?
It's mitral valve regurg.
Mitral regurg. If he told you we have a systolic murmur at the fifth intercostal space mid clavicular line, it will be
Mitral stenosis.
Mitral
stenosis.
yeah.
Mitral stenosis.
Mm-hmm.
Mitral stenosis. Okay.
Mm-hmm.
Mitral stenosis. Regurg means backflow. Regurg means backflow, and this is the diastole. The blood come back to the heart during the diastole. Stenosis means forward flow, and this is the systole. Clear?
Mm-hmm. Yes.
Clear?
Yes.
Okay. Next question.
A 34-year-old pregnant woman develops a swollen leg. Her mother and a maternal aunt also had similar problems during their pregnancies. Which of the following tests is likely to be positive? Anti-endometrial antibodies, anti-mitochondrial antibodies, anti-nuclear antibodies, anti-phospholipid antibodies, anti-thyroglobulin antibodies. So it's anti-phospholipid antibodies.
Antiphospholipid antibodies. Antiphospholipid antibodies. Very important. This is the during pregnancy recurrent DVT during pregnancy. This is an antiphospholipid antibodies, or sometimes called anticardiolipin syndrome or antiphospholipid syndrome, due to antiphospholipid antibodies. Antiphospholipid antibodies.
The fight or flight response produced the release of epinephrine. What is the primary metabolic effect of epinephrine? Alanine shunt activation, cortisol release, glycolysis, tachycardia, vasoconstriction. So it's glycolysis.
This question stayed about 3 years. They answered tachycardia. Okay, 3 years answering it tachycardia. But here, take care. This is metabolic effect of epinephrine is glycolysis. Physiological effect of epinephrine is tachycardia.
Tachycardia.
Okay, and never came before. This is what we can in the exam 3 or 4 times. Fawzia sheet, I think it came in September 2020, and it also came in April 2019 in my exam. The most common, or what is the primary metabolic effect of epinephrine is glycolysis. For any case, if he changes this, so physiological, you know now it is tachycardia.
Tachycardia, yeah.
Okay. Next question.
A 58-year-old man underwent an emergency appendectomy. Which of the following physiological parameters are consistent with sepsis? So increased heart rate, decreased systemic vascular resistance, and cardiac output will be increased. So it's C. Yeah.
Okay, so what is parameter consistent with sepsis? Sepsis, what will happen? Tachycardia, decrease the systemic vascular resistance, and increase cardiac output. Okay, this is the most common comparison between because you'll have many questions in the exam. By the way, a very nice way to solve the question of shock in the exam.
By exclusion?
By vertical method. Vertical method, the same that we said yesterday about ABG. vertical means. What will happen in a patient with sepsis? Tachycardia. Let's go here. I have C, B, D, and C. Then I read here, systemic vascular resistance. Sometimes he tell you, ask about the blood pressure. Sometimes, but here is in the septic shock, he cares about the systemic vascular resistance. What will happen for the systemic vascular resistance? Oh, it will decrease. So I'll search here. I have B, C, and D, and then I go here. Here increase completely wrong. Here decrease, it's right. And here decrease, it's right. So it's okay. I only have third parameter about these 2 points. What will happen? Cardiac output, it will increase, but here it will decrease. So no, I will go for C. This is the longitudinal. If you are trying to read in a transverse way, maybe this one will be the last one in the question, so you'll consume your time. Okay.
Thank you.
Next question.
A 50-year-old man with a 30-year history of pancolic undergoes surveillance colonoscopy, which reveals a plaque-like lesion in the descending colon. Biopsy reveals the premalignant change. What is the name of the premalignant change? Anaplasia, dysplasia, hyperplasia, metaplasia, and neoplasia. Dysplasia.
Dysplasia, this pre-malignant change, dysplasia. Anaplasia is completely malignant, hyperplasia not malignant, metaplasia is not malignant, neoplasia is actually malignant. Actually malignant, okay. But this is dysplasia. And what we said before, that most colonic polypi are dysplastic. Colonic polypi are a dysplastic polyps, adenomatous, and of the type of tubular adenoma. Most colonic polypi or the colonic polypi main histopathology are dysplastic polyps, which of the type tubular adenoma. Adenoma of the tubular adenoma, which is tubular adenoma, the most common. Next question.
A 60-year-old man undergoes cystectomy for bladder carcinoma. During surgery, the ureters are identified. On which region of the bladder do the ureters pierce the bladder wall? So anterior surface, apex, lateral surfaces, neck, posterior surface, yeah.
Posterior surface or the base of the bladder? Base or posterior surface, both came in the exam. And in every exam, one exam he gives posterior surface and one exam he gave the base of the bladder. So in which side the ureters open in the bladder wall is posterior surface or base of the bladder. Both of them right. Next question.
So if it's trigon, is it also again
he will
right?
not bring the trigon.
Okay.
Never before he brings the trigon, because the trigon, by the way, it is not, the trigon is a small area of the posterior wall or of the base. Okay, this is just the trigon is the connection, the triangular connection between the urethra and the two ureters, but it is not resembling the whole posterior wall or the whole base. Okay.
Okay. Yes, I got it. Thank you.
Okay. Continue.
A year-old patient in the intensive care unit has a tracheostomy performed via the second, third, and fourth tracheal rings. Which of interventing structure is most likely to require transection? Anterior jugular vein, inferior thyroid vein, sternothyroid muscle, thymus, thyroid isthmus. Thyroid isthmus.
Okay, this is a surface anatomy of the thyroid isthmus. It lies offers the second to the fourth tracheal ring. The straightforward anatomy question. Next question.
A 23-year-old man is assaulted and sustains a stabbing injury in the left groin. The wound is cleaned and simple dressing applied. 6 months later, the patient returns with a pulsative swelling at the site of the injury. A most proposal lesion present is abscess, false aneurysm of the femoral artery, a lymphocyte, mucotic aneurysm of the femoral artery, saphenous varix. It's pulsative and due to trauma. I read, like, that's why it's false aneurysm.
Okay, very common question also about trauma to the vessel, mostly in the groin area, or sometimes he tell you the patient is intravenous drug abuser and he's taking multiple injections on the femoral artery, and then the patient developed pulsating swelling. So it is false aneurysm of the femoral artery. Sometimes this pulsating swelling is red hot tender. There is some infection, but actually it is pulsating swelling at the femoral triangle. The abscess is not a pulsating swelling. Okay, lymphocyte is not pulsating. Mycotic aneurysm is something, it is a medical disease, not a traumatic, not post-trauma. Okay, and saphenous varix is not pulsating. So very common question in the exam in part A, and you have a big station in part B. Big station in part B about a patient, young age drug abuser, and he came to you from the GP. The GP sent to you that I sent you a patient with a groin abscess. When you examine the patient, you'll discover that it is not a groin abscess, it is a false aneurysm of the femoral artery. Big session in part B. Next question, and last question, please.
72-year-old man with a body mass index 18.4 has not eaten for 4 days following the removal of adenocarcinoma from his descending colon. His urea is found to be 12 millimeters per liter, and creatinine 346. The blood gas profile is ordered. The most likely set of result would be.
Okay.
So,
from the scenario, what do you expect this patient have? Okay, I'm answering it.
It's
This patient
acidosis, yes, acidosis.
didn't eat since 4 days. Didn't eat for 4 days after adenocarcinoma from the descending colon. High urea, high creat, and then a blood gas profile is ordered. What do you expect this patient to have? Metabolic acidosis. Okay, the patient went into shut some sort of starvation. So the patient will start to have lactic acid accumulation. Patient will go for destruction of fat, destruction of protein, for production of energy. So this patient will go into metabolic acidosis. What do you expect in metabolic acidosis?
You mean in the blood test?
What do you expect? You are now reading results of all of multiple ABG results. How can you solve this problem? This question?
So the pH is on the acidic side, yeah. The CO2 also is on acidic side, and bicarb also on acidic. So it's and acidosis.
Again. Okay. Wait. Okay. Okay, this is a question in front of me. How can I expect which one of these is my answer? As I told you, go like this. Vertical manner. I'm searching about what? Acidosis, yeah?
Acidosis, yeah.
So by exclusion, I'll exclude this. So I only have this, right?
Yes.
This patient has acidosis. So I only have this. Okay. Some sort this one will maybe acidotic. But let's start with the frank acidosis here and then go. I don't need the CO2. I need more the CO2 and the bicarb. I don't need this now. Then first one, I want here the CO2 is low. Yes, maybe some sort of compensation acceptable. And the bicarb is low. So this is metabolic acidosis, not respiratory acidosis, and there is a respiratory compensation. Go to the next slide. This bicarb is what?
Alkalotic.
Alkalotic. So this answer is also excluded. Okay, I'm doubting this result. Let's go to it. Maybe acidotic, and it's got some compensation. I have this, and then when I go to the bicarb, I found it alkalotic. So by exclusion, go for the vertical manner. Please go for the my lecture about the acid base, how to simply, very fast in the exam. You don't have any paper, you don't have any pen. How simply you can go by your mind exclusion of all these through 3 results and the street, and you start to go for this, and you are asking about the metabolic. So by rapid thinking, you are searching for metabolic, so you are looking for the bicarb. You will not look to the CO2 and O2, and then look to the bicarb. Okay, one acidotic and one alkalotic, then go back to the bicarb. If you find both of them 13, so you will go for which one has a compensation. If you find this high, no, it is not acceptable because this has a metabolic, should be compensation. So this patient mostly will have this one. Clear?
Yes. Yes.
Really, this is the most rapid thinking about any case of acid base. Okay, thank you, Dr. Alexander.
Thank you.
Thank you. Who's next?
Can I read?
Dr. Khadija. Okay.
Yes.
Okay. Starting from 91, please.
Yes. Number 91, a 16-year-old boy is hit on the left side of the face by a ball. There are no broken bones, but the boy complains of numbness of face below the eye. Which nerve has most likely been compromised? It's abducens, facial, glossopharyngeal, infraorbital, zygomatic nerve. The answer is infraorbital nerve, which supplies below the eye. Below the eye.
What
Branch
you
of
say?
maxillary nerve. Infraorbital nerve. Below the eye.
Okay. You have very common question in the exam. Numbness below the eye, which is the and numbness of lower lip. Lower lip. This will be infraorbital nerve, and this will be ventral nerve. Okay. The most common 2 questions of facial trauma in your exam. One of them you will have in your exam. The patient has a fractured jaw or fractured mandible, and the patient has numbness of the lower lip. What is the most common nerve injury? Is the mental nerve. The patient has trauma to the face with fracture to the eye or ecchymosis and numbness below the eye, which is the infraorbital nerve coming from the infraorbital canal here in the upper part of the maxilla. Clear these 2 questions, please? Concentrate. This is the correlated question I'm talking about. Every question, I will tell you what questions come in the exam. Okay, next question.
92. 74-year-old man who has undergone emergency major abdominal surgery 2 days previously is noted to be confused. He has been on furosemide for mild heart failure. The plasma sodium is 122 millimole per liter. Inspection of fluid chart shows that he has been written up for 1 liter, 4-hourly intravenous 5% glucose infusions. What is the most likely cause for the hyponatremia? The patient is given furosemide and the fluid he is given is only the glucose infusion. no
Mhm.
saline. Maybe these two
Mhm.
causes. The answer B, excessive sodium-free intravenous fluid administration. Okay.
Yes, exactly.
1 liter
Very common
5% glucose 4
scenario in the
hourly.
exam.
It's too
Patient,
much.
we agreed yesterday, the patient post-operatively, what regimen he take?
It takes 1.5 liter 5% glucose and 1 liter of sodium chloride or normal saline.
Okay. Any disturbance in one of these, the patient will go in a problem. If he took only saline, he will go for hypernatremia. If he will go for only glucose 5%, he will go for hyponatremia. This patient in furosemide, he is already losing sodium in urine. And this patient is taking 1 liter every 4-hour glucose intravenous suspension, 4 hourly. So the patient is taking only water. So the patient will go for excessive sodium-free intravenous fluid administration. This patient will go for the same problem of the TURB, dilution hypernatremia like TURB. Like TURB, he will be confused, agitated, has pulmonary edema, has brain edema, with all the symptoms of these things. Next question.
93. The Cori cycle important in lactate metabolism in the septic surgical patient. It is used to describe a pathway in which glucose is metabolized anaerobically to lactate in one tissue and the lactate converted back to glucose in another. Which one of the following relies on this cycle to meet all of its body needs? The erythrocyte, hepatocyte, leukocyte, osteocyte, pneumocyte. Erythrocyte depend on Cori cycle to meet its energy need.
Erythrocyte. Very common question in the exam, and it came in last January 2021, in September 2020. September 2020, and it came in 2018, 2019, April 2019 in my exam, and here is in Fawzia sheet. Cori cycle, erythrocyte depend on Cori cycle in gaining its energy needs.
Sorry, Dr. Rami, I think it's hepatocyte.
No, this question is now written in MRCS and is answer erythrocyte as well.
Okay.
Okay, we can confirm it again, no problem. But the erythrocyte depends on Cori cycle in getting its energy.
All of its energy.
On all its energy. Make sure of it, but I'm sure this is erythrocyte. Okay, next question.
94. After receiving an intramuscular injection in the buttock, a 25-year-old man complains of inability to evert his foot. Which nerve is most likely to have been injured? Foot eversion associated with common peroneal nerve. The option is A, common peroneal or common peroneal component of sciatic. Common peroneal nerve.
Okay, why you choose common peroneal here? Because here the injection in the buttocks. Okay, I just want you to, because many questions come in this point. Many questions came before this point. The most common is trauma or fracture of the neck of the fibula or compression by cast of the neck of the fibula. This guy. We have superficial peroneal nerve. Superficial peroneal nerve. It supplies the everters and it causes its action, eversion of the leg. Okay?
Yes.
Plus, it gives sensation to the dorsum of the foot. Plus, sensation of the dorsum of the foot, except for the first whip space. Deep peroneal gives the muscle of the anterior compartment of the leg, makes dorsiflexion of the leg. and dorsiflexion or extension of the back 2 plus web space. Okay, clear يا شباب? So we have common perineal give us 2 superficial with deep. Superficial makes eversion plus sensation dorsum of the foot. I consider it the dominant one. Deep give me dorsiflexion plus first web space. Okay, here is motor and here is sensory. What come in the exam? Most questions come in the exam, one of these components or the common perineal. Most questions in the exam come fracture of the neck of the fibula or compression by the neck of the fibula by cast or during intraoperative compression, whatever the site of compression on the lateral aspect of the knee. And he tell you, the patient loss eversion and loss of sensation at the dorsum of the foot. So what will be?
Impression and dorsum superficial.
Loss of eversion and sensation at the dorsum of the foot. This will be the superficial perineal compartment of the common perineal nerve. Okay. Sometimes he tell you the patient loss of dorsiflexion, okay, but sensation is normal on the dorsum of the foot. So it will be, or sometimes he tell you loss of sensation on the first web space, but mostly he will tell you sensation of normal or is no loss of sensation on the dorsum of the foot. This will be deep perineal. So if this is confusing, please answer me. All open your mic. Again, he tell you patient loss of eversion and sensation at the dorsum of the foot. If you found in the question in the answers of the exam superficial perineal, go for it. If you didn't find, you will find the common perineal. Sometimes he will write like this fibular or superficial component. Another thing, sometimes, and we will all this question will be solved. The patient lost his dorsiflexion with normal sensation or loss of sensation on the first web space. So it will be
Deep perineal.
deep perineal. Deep perineal. If I didn't find deep perineal, I'll go at a level above and I'll see common perineal.
Perineal.
Okay, common perineal. Sometimes he tell you the patient lost dorsiflexion of the foot with loss of sensation. The patient lost dorsiflexion of the foot plus loss of sensation on the dorsum of the foot. And he will give you in answers. Superficial perineal, deep perineal, sciatic, common perineal, and so on. What you will choose?
Common
perineal.
common perineal.
Common perineal يا شباب. كده يبقى all of this injured.
Yes.
But loss of sensation on the dorsum of the foot, including the first web space.
Yeah,
Including
that's
the
deep
first
perineal
web
only.
space. Okay, so take care.
Yeah.
If he told loss of eversion only, so this is a superficial perineal. Loss of eversion, loss of dorsiflexion. Look, what about sensation? Sensation intact, so it is only deep perineal. Sensation is not intact, so it is the common perineal. Here is rare question. He told you injury. He told you injection in the buttocks. Sure. In the buttocks, he will not injure the superficial peroneal or deep peroneal. Sure, he will injure the common peroneal component of the sciatic nerve. Other question we will pass, but this picture, we will have about 20 questions in our recall. We will have about 20 questions in our recall about this picture only. Clear?
Okay.
Clear.
Clear.
Okay, yalla. Close your mics. Next question.
95. A 73-year-old man with a history of irregular bowel movement present with dysuria, pneumoturia, and an Escherichia coli urinary tract infection. CT scan show a mass involving sigmoid colon and the bladder. What is the commonest cause of this presentation? Adenocarcinoma, sigmoid colon, colonic diverticular disease, Crohn's disease, transitional cell carcinoma of bladder, ulcerative colitis. Here is dysuria and pneumoturia, E. coli urinary tract infection, this colovesical fistula, and the tumor involving sigmoid colon and bladder, mostly due to colonic diverticular disease. Answer B, colonic diverticular disease.
Okay. Why not adenocarcinoma of the sigmoid colon?
Because of involvement of bladder.
Okay, adenocarcinoma can involve the bladder and make can involve the bladder. Okay,
There are
as
no
I told
features of
you,
malignancy.
the exam is so simple. Sorry?
There are no features of malignancy. No weight loss, no.
Perfect. That I want you. If he wants you to think about adenocarcinoma, he will give you some sort of malignancy. He told you here irritable or irregular bowel movement present with dysuria. Okay, and pneumoturia, Escherichia coli. Escherichia coli. This is E. coli is present mainly in the GIT, and CT show mass involving the sigmoid colon. You know, if this patient has a cancer and mass, and this mass reach it to invade the bladder and make a fistula, this patient should be cachectic, loss of appetite. The mass should first obstruct the colon. And the patient in CT, he will not tell you bas, just only mass and multiple lymph nodes and mass, annular mass in the colon, and so on and so on. And this patient will not only have just mass with the bladder and making fistula. So simply, this is a diverticular disease. The other thing, what is the most common cause of left iliac pain in old age?
Yes.
Diverticular disease. Most common
Diverticular
cause, most common than cancer. Diverticulitis. Keep it precise. This is diverticular disease. Maybe with diverticulitis means infection of the diverticulus. Because in part B, you have to differentiate between diverticular disease and diverticulitis. You have to differentiate between appendix and appendicitis. This is diverticular disease. Not important to be inflamed. The patient has multiple bully, diverticulosis. Okay, so it is diverticular disease until proved otherwise. So diverticulitis or diverticulitis is the most common cause of pain, left iliac pain in old age, and that's why it is the most common thing that can make an chronic inflammation and a bladder with the bladder with fistula. Clear this? Is this the age of Crohn's disease or
No.
ulcerative colitis? Most if it is not all cases of Crohn's and ulcerative colitis in the exam will be in the age of 20 and 30 and maximum 40 years. I tell you this is an autoimmune disease of the middle age and young age. If go for the old age, you have to think about this disease. Okay. If this right, why is this not right? It can't have a cancer brother and invade the colon and make a fistula, or invade part of the intestine, loop of the intestine, and make a fistula. Come on, but there is no features here, decent. Nothing here referring to any malignancy. Okay, thank you. Continue, Dr. Hadiga.
96. A 7-year-old woman. 7-year-old woman in the recovery area receives 28% oxygen by mask. ABG shows 7.2 pH, oxygen 12 kilopascal, carbon dioxide 10 kilopascal. Reduced sensitivity of which receptor is most likely to be responsible for this blood gas peak. Carbon dioxide is high, this acidosis. Reduced sensation is central chemoreceptor because if central chemoreceptor is stimulated, it will be hyperventilation.
Okay, this patient has a 72.2. She has normal oxygen, but she has a very high CO2. Okay. Reduced sensitivity of which of the is most likely responsible to the blood gas picture? Exactly, central chemoreceptors. Because it is sensitive to pH and CO2. Central chemoreceptors responsible for pH and CO2. Okay, just wait, I'll send you a very nice picture on the group. Okay, next question, please.
97. A 76-year-old woman falls and sustains an intertrochanteric fractured neck femur following operative fixation. Her recovery is prolonged. She is discharged to a rehabilitation unit. 6 weeks after her original operation, she is readmitted. She is drowsy, hypotensive, and bradycardic. ECG shows low voltage complexes and a prolonged QT interval, under activity of which following glands gives the best explanation of the clinical picture. Adrenal, pancreas, parathyroid, pituitary, thyroid. It's thyroid, and this low voltage complex and prolonged QT interval is due to hypothyroidism. These two ECG changes.
This question.
So, the gland thyroid.
This question was in 2000 in January 2020, and most courses answer it parathyroid gland.
Parathyroid, they thought hypocalcemia, but the low voltage complex.
All courses except our course in last September and last January only answered the thyroid gland, because low voltage complexes is pathognomonic for thyroid gland and hypothyroidism. Okay. Don't forget this question because very confusing question, and that's why they bring it last exam. Expect to find it again, no problem. Next question.
Number 98, a 36-year-old man falls on his outstretched right hand. Examination reveals tenderness in the anatomical snuff box. Which one of the following tendons forms a boundary of the anatomical snuff box? Forms a boundary. It has two boundaries. Here says Abductor pollicis brevis, no extensor carpi radius brevis, no extensor carpi radius longus, no extensor no extensor pollicis longus. Extensor pollicis longus is the
okay, boundaries of the anatomic
lateral.
notebooks is very important. Very important. Okay. If you put the hand in the anatomical
Is the
anatomical
posterior
position.
boundary. Yes.
Okay, you have the posterior boundary or the medial boundary, medial or posterior boundary. It will be the extensor pollicis
Extensor
longus.
pollicis longus.
Okay, if he tell you the lateral or the anterior boundary, it
There
will be
two.
the extensor brevis plus the abductor longus.
Yes.
Put your hand in front of you in the anatomical position. Exactly. The lateral boundary is the anterior boundary, and the medial boundary is the posterior boundary. Sometimes he tell you lateral and medial. Sometimes he tell you anterior or posterior. So this is in the anatomical position. This will be posterior and medial. This will be posterior or medial. And this will be anterior
or lateral.
or lateral. Anterior or lateral. Anterior or lateral, we have two. Posterior or medial, we have the extensor pollicis longus. Clear?
Clear.
He plays with some words when he wants to change the question.
99.
Next question.
A 65-year-old woman with metastatic breast cancer is admitted to hospital, confused and acutely unwell, with nausea and vomiting. Her vital signs are within normal limits. What abnormality is most likely to contribute to her clinical condition? Hypocalcemia, hyperkalemia, hypocalcemia, hypokalemia, hyponatremia is hypercalcemia due
Okay.
to breast cancer metastasis mostly to bones and
Okay. This is the most common picture you will face in our collection. Most common of them about the osteoporosis, osteomalacia, and bone metastasis. Okay, this is the most common question you face. You'll face this one, you'll face this one, you will face bone mets. In bone metastasis, you have a high calcium, and the patient will come with this picture. Patient is not feeling well, nausea and vomiting, and drowsiness and abnormality, and so on. And he can give you a picture, ECG picture of hypercalcemia. Bone metastasis equals hypercalcemia. Osteomalacia, like the last exam, equals hypocalcemia. Hypocalcemia. Osteomalacia means the bone is less mineralized, is deficient of mineralization. There is normal bone, but not mineralized. This is osteomalacia. The other thing is an old age woman, post-menopause, and the patient has osteoporosis, and he tell you what you expect for her calcium level. In osteoporosis, the calcium level is normal. Again, osteoporosis, the calcium level is normal. The bone is deficient in bone matrix, but the amount of bone matrix present inside the bone will be well mineralized because there is normal calcium level. Osteomalacia, I have bone without calcium. So this will be hypocalcemia. In bone mets, I will have bone destruction due to osteoclastic activity, so I'll have hypercalcemia. Clear? These three came in the exam and very frequent in the exam about the calcium level in these three diseases. Anyone don't understand, raise his hand. About osteoporosis and osteomalacia, it's clear? Okay, clear. So no one, so it is clear. Next question and last question, please.
100. A 4-year-old boy presents to emergency department with a 2-day history of fever, difficulty walking, and is unable to weight bear on the right leg. He has been on oral amoxicillin 250 milligrams 3 times a day for chest infection over the last 5 days. He is irritable with a temperature of 39.4 degrees centigrade. He does not allow examination, keeps his right hip flexed and abducted. Blood test WBC 12.3 to 10 is raised, I think. C-reactive protein 146, hemoglobin 11.3 gram per dl. What is the most likely diagnosis? There is fever and increased WBC count and cannot unable to weight bear on the leg. Maybe it's infection, the acute avascular necrosis of hip, dislocation, perthes, septic, septic arthritis. Septic arthritis.
What is this picture? What is this picture? This inflammation, this infection. That's what I'm telling you. If you want to direct your brain in the exam, this is infection or this is inflammation, he will give you the constitutional symptoms of infection and inflammation.
Yes.
Okay.
Fever.
So I'm from here. Patient has high TLC, high C-reactive protein. High C-reactive protein, fever, pain. This is infection. This is bacterial infection. Let's go to the answer. This is avascular necrosis. This is dislocation. This is Perses disease. This is left upper femoral epiphysis. No, this is septic arthritis. The only one is bacteria. The only bacterial infection on all of these answers is septic arthritis. Yes?
Yes.
Easy. Got the idea about he wants you to know that this is a constitutional symptoms due to in the exam. This is a 4 years old. Maybe he slept upper femoral epiphysis, maybe Perses disease, maybe dislocation. Okay, there is no history about the trauma to say. But if in the exam and they give you the history, this history simply, and he tell me, doctor, what is your differential diagnosis? And you started with Perses disease or strep upper femoral epiphysis, really you will miss most of the result in part B. If you didn't start with, this is infective arthritis or septic arthritis. What else? He will tell you what else, yeah, maybe Perses disease, maybe slept upper femoral epiphysis, maybe, and maybe. But you have to tell the first differential diagnosis to be right. Thank you, Dr. Hadiga. Who's else who can continue, please? We need to take 20 more questions, please. If we still we have more questions.
So may I start?
Who? Dr. Wagia?
Yes, sir.
Yes, okay.
101, 35 years old woman present with recurrent septic peptic ulceration. Recurrent peptic ulceration. She is on proton pump inhibitor and previously received Helicobacter pylori eradication therapy 3 months ago. Which of the following is likely to be raised on venous blood testing? So A is cholecystokinin, B is gastrin, C is histamine, D is pancreozymin, and E is secretin. So answer is gastrin.
This is the most common scenario about gastrin or gastrinoma or Zollinger-Ellison syndrome. Patient, young age, recurrent peptic ulceration in spite of taking medication of H. pylori. This is a common picture of, and he will ask you about the hormone or the diagnosis. Can be, if he asks you about the blood testing hormone, it will be gastrin hormone. If he asks you what you expect to be the diagnosis, it will be gastrinoma or Zollinger-Ellison syndrome. Zollinger-Ellison syndrome. The most common scenario about this triage: gastrinoma, Zollinger-Ellison syndrome, gastrin level, or the patient young age receiving anti-helicobacter and anti-proton pump medication and still have recurrent peptic ulceration. Okay?
Yes, sir.
Okay.
Okay. Next question. I'm telling you that this picture have also many questions in the exam. Okay.
102. A 55-year-old man presents with backache. Neurological examination reveals lack of extension of left great toe. Which of the following spinal cord segment are likely to be involved?
Okay. What we said yesterday, big two. What is the root myotome for big two?
S1.
L5.
Oh my God.
L5.
Again. Again and again. Okay.
Dorsiflexion is L4, big toe is L5, and plantar
L5.
flexion is S1.
I'll take it from above.
Okay.
To bend your thigh. Wait. Change the color. To bend your thigh up, it is L2. To flex, to extend your knee, it is L3. To dorsiflect your, all this anterior movement. Okay. To flex your knee is L3. To dorsiflect your foot is L4. To extend your big toe or dorsiflect your big toe is L5. To plantar flexion your foot is S1. Forget it again. What's more important to you? Most more important to you this. All of them important to you, by the way. Forget about L2 now. You will be asked about this in myotome in part B. But extension of the knee, main root is L3. Dorsiflexion of the foot is L4. Big toe extension or dorsiflexion is L5. Plantar flexion is S1. Clear?
It's clear.
Yes, sir.
Okay, so here he tell you extension of the great toe. What will you
Yes.
search in your mind? You are searching about L5.
Okay.
Saying go here, go here. What will be your answer?
L5.
By exclusion, L5 is here.
Okay.
Clear?
Yes, sir.
Okay. Thank you. Next question.
103.
Again to our
Yes.
picture. Okay.
A 34-year-old man is seen in an emergency department with a fibular fracture following football match. On examination, he is noted a loss of foot eversion. Which area of his skin should be examined to confirm the loss of cutaneous distribution of the affected nerve? Along the lateral aspect of the foot, along the medial aspect, cross the dorsal surface of foot, on the plantar surface of foot, or over the heel? So the answer is cross the dorsal surface of the foot.
Okay, what is the nerve here? He didn't mention the nerve. He wants you to guess the nerve and after you guess the name, you guess the area.
Superficial peroneal. No?
Loss of eversion is superficial perineal. So my mind will run fast to go for all features of superficial perineal. Eversion and
sensory loss of the dorsum of the foot.
Sensory loss of dorsum. So when I check this one, is the dorsal surface of
the foot. Yes.
Okay, clear?
Yes.
You will have many questions about this. Common perineal, they like it in the exam like their eyes, in all its features and all its varieties. Whatever it is injured up in the buttocks during amphi, it is injured down, it is injured with fracture, fibula, and so on. Okay, next question.
A 68-year-old man with insulin-dependent diabetes presents to the pre-admission clinic prior to the surgery for rectal carcinoma. His creatinine is found to be 590 p-mol per liter. He is referred to a renal unit where a measure of his glomerular filtration rate is done. Which of the following best describes why insulin could be used to measure his GFR? So A is it is filtered and not reabsorbed. It is filtered and reabsorbed. C is it is filtered, secreted, and reabsorbed. D is it is filtered, secreted, but not reabsorbed. And E is it is not filtered, but it is secreted and not reabsorbed. So answer here is it is filtered and not reabsorbed.
Okay. I want you to know also 2 points regarding this, because you'll find many questions about inulin and para-aminobutyric acid. Inulin, the question you will be asked about this, most of them. What is inulin used for? Measuring what?
GFR.
GFR. Para-aminobutyric acid?
Renal blood flow.
Renal plasma flow. Renal plasma flow. Okay. Another question about inulin. Why inulin is used?
Inactive or
Because no. Because it is filtered but not secreted or reabsorbed. Okay, filtered but not secreted or absorbed. Another thing I want to show you, GF inulin. Oops. We are not recording. When we stop the recording, Shabab?
I think since we started.
And now, okay. I think from here, yeah.
Yes, 105.
Okay, no problem. Okay, I think we explained this one. So we can do like this. We explained this, and here we said the most common type of tumor, brain tumor in adult is glioblastoma, and the most aggressive form is the glioblastoma multiforme. Here is the same. We said the most common breast cancer in females is the invasive ductal carcinoma. Most questions asking about the most common cause of this one, the Third question here is we are recording now. The third question here is about in hypovolemia. What is the first response for hypovolemia? Because this question is very common. It comes 2 times per year in the 3 exams. We said here the most common is baroreceptors is mechanoreceptors. Mechano or mechanical receptors respond to stretch in blood vessel wall. So in hypovolemia or loss of blood or loss of volume, it will be less stretched and it will fire to increase tachycardia and trying to compensate for the low blood volume. So baroreceptors or mechanoreceptors are the first. The first response is not the kidney, and it is not the adrenaline. He means by the kidney, but the renin. Sometimes he tell you the first response is the renin, angiotensin, aldosterone system, or the baroreceptor. No, baroreceptor is the first response, followed by the kidney, the renin, angiotensin, aldosterone system. Clear? Chemoreceptors are sensitive to pH and CO2 level. Okay. Okay, Shabab?
Yes, sir.
Okay.
$108. Vitamin K is required for normal bleeding, for normal blood clotting. Which of the following statement is true about the effect and the availability of vitamin K? It affects A, it affects platelet function. B, is causes bleeding if it taken in excess. C, is provided only by fresh food. D, is depleted by broad spectrum oral antibiotic, and E, is vitamin K absorption is affected by the resection of terminal ileum. So the answer is E. It is affected, its absorption is affected by the resection of the terminal ileum.
Okay, so what is required for normal blood clotting? What should the following say is true about effects and the availability of vitamin K? So it is affected by absorption by terminal ileum. Absorption is affected by terminal ileum. Why does this happen? Can you explain to me?
So because in the terminal ileum is responsible for the absorption of vitamin K here. So if the resection of terminal ileum is taken place, so if we can have the vitamin K, it won't be absorbed since the terminal ileum is not there.
Anyone has another explanation?
Vitamin K is lipid soluble vitamin.
Okay.
And the bile
So there is
salts
a
are-
lipid malabsorption because of terminal ileum resection.
Mm-hmm. Why special is the terminal ileum?
I think for the bile absorption also in terminal ileum.
Shabab, bile salt absorption is happened in the terminal ileum and is responsible for the anterior hepatic circulation. About 90% of bile salts is, or 99% absorbed in the terminal ileum to go back for the anterior hepatic circulation. No absorption of bile salts, okay, will disturb the anterior hepatic circulation and the lipid and the emulsion of fat and the lipid soluble vitamins. Okay. So vitamin K will be affected by resection of the terminal ileum. Okay. This patient will have resection of the terminal ileum. This patient will have steatorrhea. This patient will have gallbladder stones. Okay. and one of them vitamin K deficiency, not vitamin K, all the vitamins K, A, D, A. Okay. Next question.
Dr. M, is vitamin B12 also affected?
Okay, but keep vitamin B12 for its place. Keep here terminal ileum, you will be mostly with, we will have some questions about where is vitamin B mostly absorbed and where is vitamin B mainly absorbed in gastropathy or in atrophic gastritis. Okay, because of the intrinsic fact. He will not confuse you. He want to tell you that we have atrophic gastritis or gastropathy. Okay, so what will happen? You will have vitamin B deficiency, and this patient, because of affection of the intrinsic factor, and this patient will suffer from amegaloblastic anemia or pernicious anemia, because vitamin D is very important for division of the blood cells.
Okay.
Mitosis of the blood cells. Okay, we'll have many things. And okay, yeah, next question.
109, in septic shock, norepinephrine, noradrenaline is used to increase the systemic vascular resistance. This action is a result of stimulation of which of the following receptors? A is alpha 1, B is alpha 2, C is beta 1, D is beta 2, and E is gamma 1. And answer
Okay.
is here is alpha 1 receptor.
Okay. Norepinephrine is used to increase systemic vascular resistance. This action is a result of stimulation of which is the following. The main action of norepinephrine is on alpha 1 to direct this action for this action. By the way, the most common what we call if you have to give inotropic drugs and septic shock, the most common is norepinephrine or noradrenaline. And the main action of it on alpha 1 to make vasoconstriction, because this patient will have decreased systemic vascular resistance. Okay. Hello.
Yes,
Yes.
yeah. Okay.
شباب, septic shock,
Decrease systemic vascular resistance.
septic shock. The main problem is decrease in systemic vascular resistance. What I want to give, norepinephrine to alpha 1 vasoconstriction. Okay.
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 Yes, sir.
Yes.
Okay. Type. Cardiogenic shock. What is the main problem?
Increase
Cardiac
cardiac output.
No pump, weak pump. What I want to give?
Dobutamine.
Dobutamine. Main action on
Beta 1.
beta 1. So increase the heart rate. Okay. Anaphylactic shock. The main problem is bradycardia and vasodilatation. What I want to give? I give adrenaline. Adrenaline IM. I think 1 to 1,000. This one's dose like this. 3 main types of shock. What is the best medication? First medication you give. Septic shock, noradrenaline, because it works in alpha 1, vasoconstriction. Cardiogenic shock, mainly give dobutamine because it works in beta 1. And anaphylactic shock, you want to give adrenaline because it works in beta 1 and beta 2 as well, and the bradycardia to increase the heart rate. and alpha 1 also makes vasoconstriction, but mainly they want the effect of the bradycardia, even in neurogenic shock sometimes. But this is here. In anaphylaxis, know that you give adrenaline IM. Cardiogenic shock, you give dobutamine. Septic shock, you give norepinephrine. This is the most important three. Sorry. Dobutamine. This is the most important three you have to know. Okay. Okay. In part B, you know that dobutamine, what's called, it is dose dependent. Dobutamine and low dose works in D1 and D2 on the renal vessel to increase the renal blood flow. In medium dose, it starts to work in beta 1 to increase the heart rate. If you give a high dose, it will start to act on alpha 1 to increase the contractility and vasoconstriction. Very important in part B, this one, by the way. Next question.
110. A 10-year-old child presents with progressive facial weakness and a squint. On examination, there is a lower motor neuron facial weakness and failure of abduction of one eye. The MRI shows a small intrinsic mass lesion within the central nervous system. Where is most likely it is located? So A is cerebral vermis, B is cerebral tonsil, C is medulla, D is midbrain, and E is pons. So the answer here is pons because the facial nerve originates from pons.
Okay.
Since we discussed earlier that 2, 3, and 4 originate from midbrain, and
exactly, abducent
5,
nerve,
yeah.
6th cranial nerve originate from the pons. So
Yes.
I'm going, and that's why I'm telling you this diagram is very, very important. 2, 2, 4, 4, 2 from cerebrum, 2 from midbrain, 2 from
Yeah.
pons, and then 2 from medulla. You
Medulla.
can easy catch
Yeah.
the nerve affected, and then you go. If you have cerebellopontine angle, it will be the facial angle. Vestibulocochlear. If you have just, he told you, by the way, questions are repeated. If you have a problem with the abduction of the eye, so it is, I go around to be in, it is the abducent nerve, 6th cranial nerve, so it comes from the pons. Okay, thank you, Dr. Ogiha. Another thing, question, who is ready? Dr. Akram or Dr. Ege? Ready?
Okay.
Okay, Dr. Ege, you can continue, please.
Okay. Question number 111. A 65-year-old man with a history of ischemic heart disease has an abdominoperineal excision of the rectum, after which he is stable. 2 days later, he is clammy, has cool peripheries, tachycardia, and blood pressure of 80/60 millimeter mercury. His temperature is normal. What is the most likely cause of this? For a 65-year-old man with ischemic heart disease, presenting with features of shock, the ischemic heart disease is pointing towards cardiogenic shock. And there is no temperature, so we will not think of septic shock. The cool clammy eye extremities, okay, suggest cardiogenic or hypovolemic, but because of the ischemic heart disease, that's what points towards cardiogenic shock.
Okay, let's go here. I'm new to this question and I want to go here. Okay, it is anaphylactic shock.
Anaphylactic shock.
What is anaphylaxis here in the
There is nothing causing a reaction or acute atopy or anything like that.
Nothing. Patient did an operation and he have a history. Every word give you in the scenario have an index and have a role play in your answer. Okay. Why he give you ischemic heart disease? He want to direct your brain. This patient has a problem in his heart, and he did an operation. Okay, anaphylactic shock, I have nothing in the scenario to choose. If you choose anything here, go to the scenario. Why did you choose this? Because 1, 2, 3 in the scenario. Anaphylactic shock. Do you have anything here in the scenario that you can judge to choose anaphylactic shock?
No.
Okay.
No.
Cardiogenic shock. Yes, the patient is ischemic
Ischemic
heart.
heart
The
disease.
patient has tachycardia. The patient has clammy
Clammy and
clammy cool peripheries because low stroke volume. Okay, the patient has a low blood pressure because low stroke volume. Yes, okay, so this is in my mind. Hypovolemic shock. Any picture here about any hemorrhage in the
hypovolemic shock.
patient?
There is
Yeah.
no picture of blood loss. The only thing that is thinking, only the cool clammy peripheries that may want to drag you there. But there's no
If there is
picture of blood loss.
hypovolemic shock, he will tell you the patient has tender abdomen, distended abdomen. The patient is what? He didn't see.
Yes.
He told the patient he has a normal temperature. Okay, and the patient have blood in the blood. This patient will have go-for peritonitis and he will have a high temperature. Okay, neurogenic shock.
Yeah, because of the cold clammy peripheries, I will not think of neurogenic because neurogenic will always cause warm, and neurogenic also causes what do they call it? Bradycardia.
Bradycardia. The only shocks that will cause bradycardia is neurogenic shock. The only shock, this table is very, very important. The only shocks that will cause bradycardia, warm, dry skin is, so this is not the picture of neurogenic shock. Septic shock. Is this a picture of septic shock?
No, there will be fever somewhere at least.
Warm, septic shock. Where is septic shock? Pink, warm, flushed skin, and tachycardia. Not clammy and cool peripheries. And no fever. He told you the patient has no fever. So why exclusion? The only one here is cardiogenic shock. Okay. By the way, this table is very important. You have to read many times because all of this you will be asked, and you will have tables about picture about here. Make you a table like this. We will find some question like this. Okay. And he tell you heart rate, cardiac output, systemic vascular resistance, and blood pressure. And he start, yeah, CV, sometimes CVP, yes, sometimes CVP. And he start to give you some options like this. He will make you like this in the exam. Really, in the exam, he will make like this for you. He will make like this for you. Really. Which one will be the picture of this patient? And you have to know that this be by exclusion. Okay, I'm talking about neurogenic shock. Okay, so I'll choose the bradycardia. The only shock that makes bradycardia. Okay, I'm talking about septic shock. The only shocks that make decrease systemic vascular resistance. So it will be this septic shock. Okay, and so on. This table is very important.
Okay, question 112. A 55-year-old man presents to the general practitioner with a 4-month history of feeling tired. The general practitioner notes breast enlargement. Investigation reveals a thyroid stimulating hormone of 0.2, which is low, and
Yes.
free T4, thyroxine 6, which is also low.
So
they are
TSH
low.
and T4 is low. So what's your answer?
The answer is secondary
Without reading the
hypothyroidism.
answer.
It could be secondary hypothyroidism or sick thyroid syndrome, but
To be what? What you expect?
sick thyroid syndrome. Secondary hypothyroidism or sick
thyroid syndrome. Okay, sick thyroid syndrome. You said sick thyroid syndrome, or what else?
Secondary hypothyroidism.
Okay, So this or this, I'm with you. Let's go what we did in the last question. Secondary hypothyroidism. Why you said secondary hypothyroidism?
Secondary hypothyroidism, the T4 is low.
What?
They are all low. In secondary hypothyroidism, all hormones are low.
Okay. Okay. So this may be right. Sick thyroid syndrome. Why did she sick thyroid syndrome?
Still the same thing. All hormones are low, but the difference
Okay.
here is
You said sick.
there,
Yes.
yes.
Okay.
The
Where
difference
is the
here,
sick?
yes. There's no patient. The patient has
Sick,
to be
well,
in the hospital for a long
sick,
time.
sick thyroid syndrome is a patient admitted in the ITU or ICU or post-operative or severely ill in hospital or admitted for a long time, and ill, sick patient in hospital or an ICU or ITU. Okay,
Yes.
that's all. Okay,
Yes.
clear.
Yes, it's clear.
This is a simple picture of secondary hypothyroidism. Simple picture. Okay, next question.
A 40-year-old woman presents with a parathyroid parathyroid tumor. A biopsy revealed extensive perineal invasion, which is the most likely pathology. The answer, the adenoid cystic carcinoma, which has a predominant, which usually affects the nerves, the facial nerve.
So,
So adenoid cystic carcinoma is the answer.
okay. This is the most important thing you have to know about parotid tumors. The most common benign tumor is
Pleomorphic adenoma.
pleomorphic adenoma. The most common malignant tumor is
Mucoepidermoid.
mucoepidermoid. If he added malignant tumor with facial nerve or perineural invasion, you will add adenoid cystic carcinoma. Okay. Again, most common benign, pleomorphic adenoma. Most common malignant, mucoepidermoid. Most common malignant with perineural invasion is adenoid cystic carcinoma. Okay. Clear?
Yes, clear. We have to cram it like that. Yes, clear.
Okay. Continue.
A 50-year-old man presents with malaise, abdominal pain, weight loss, fever, and myalgia. Polyarteritis nodosa is also associated with all of the following, except erythema nodosum, livido reticularis, mononeuritis multiplex, DNA fold infarct, palpable purpura. Answer erythema nodosum. I don't know that.
Polyarteritis nodosa is associated with all of the following except erythema nodosa. Okay. It's one of the rare questions didn't repeat many times before. I didn't see it since only on Fawzia sheet, but just know it. Malaise, abdominal pain, weight loss, fever, myalgia, polyarteritis nodosa is associated with all of the following except erythema nodosa. Okay. Just know it like this.
Yes.
Never repeated it. I didn't see it in exam. We will do all the recalls till 2020, 2021. You will not find it again. but know it. Maybe you are lucky, like some exams come sometimes hard, so it may be one of them. Okay. Next question.
115. A 30-year-old woman undergoes subtotal thyroidectomy. 5 days later, the wound appears red and inflamed. Which of the following is most likely causative organism? This patient has a surgical site infection. Most common cause should be Staphylococcus aureus in the surgical patient.
Mhm. Staph aureus. Okay. Patient undergoes subtotal thyroidectomy and then later wound infection, which is the most likely cause of again. Most common organism for surgical site infection is Staph aureus. Most common organism for surgical site infection is Staph aureus. Okay, next question.
A 50-year-old man complains of recent onset diplopia. On examination, he is unable to look inward and downward with his right eye. The most likely diagnosis is a lesion of the A. abducent nerve, B. ciliary ganglion, C. nasociliary nerve, D. oculomotor nerve, and E. trochlear nerve. Trochlear nerve, SO4, yes, supraoblique. It supplies the supraoblique muscle. It deviates the eye inward and downwards. So
Okay.
that's why it's a choice.
About palsy, about cranial nerve palsy. You have 3 cranial nerve. Okay, most easy is 6 cranial nerve, lateral rectus. The patient has medial deviation. Yes,
Yes.
the patient have medial deviation or unable to look outward. This is 6 cranial nerve or lateral rectus. Clear? Or the patient can't, like the previous scenario, abduct his eye, can't abduct his eye. Fourth cranial nerve responsible for looking to near objects or go downwards the stairs. When you are going downwards the stairs, you are looking down to your feet. So downward and convergence. This is the superior oblique. If you can't do this, so you have a problem with the superior oblique or the trochlear nerve. Okay. Third cranial nerve. This is ophthalmoplegia because it's responsible for most of the extraocular muscles, and there is a pathognomonic feature in this nerve injury not present in other nerve, which is the patient will present with ptosis because of the levator palpebral muscle. Whatever the scenario will give you of ophthalmoplegia, but this is rarely to bring this. But if he told you the patient has ptosis of the eye plus ophthalmoplegia, this will be the third cranial nerve. Patient can't look inward and downwards. This will be the fourth cranial nerve. Patient can't go downstairs or can't look to near objects. This is fourth cranial nerve. Patient can't abduct his eyes. This is sixth cranial nerve. Easy and clear?
Yes.
Okay. Next question.
A 57-year-old heart transplant recipient is keen to join the cardiac rehabilitation program. Which of the following factors is most likely to increase cardiac output in this patient during moderate exercise? A, decrease in negative intrathoracic pressure. B, decrease in venous tone. C, a decreased ventricular compliance. D, an increased atrial filling. And E, an increased intrapericardial pressure. For post-cardiac transplant, I think the vagal and the parasympathetic and sympathetic stimulation to the heart is lost. So the only thing that can increase heart contraction is increased atrial filling. That's what I'm thinking.
Okay. And this question is with the same scenario and the same choice in January 2021. The same scenario and the same answer in January 2021. How the patient with heart transplant can increase the cardiac output during moderate exercise. It will be through increase the atrial filling. Increase the atrial filling. Forget about ITS, okay?
Okay.
Next question.
69-year-old man with rectal cancer undergoes a low anterior resection. Liver is disease-free. The pathology of his tumor was reported as a large tumor invaded the rectum into the mesorectum. Two nodes of 24 lymph nodes close to the tumor were carcinoma on histology. The tumor was completely excised. What is the correct pathological staging of his tumor? As long as lymph nodes are involved and the tumor has already spread into the mesorectum, then that should be due classification C.
Okay, as we say, A is limited to the mucosa, B is extending to the muscularis mucosa, to the muscularis propria, C started to reach the serosa, D distant metastasis. Okay.
Yeah.
Simply, Duke's classification has many pictures, but this is the simple picture. A limited to the mucosa, B reached to the muscularis propria, not the muscularis mucosa, muscularis propria, the muscular layer. C reaching to the serosa, D distant metastasis. Next question.
A 21-year-old man is admitted to the emergency department with a stab injury to his right chest. The pulse rate is 110 beats per minute and blood pressure is 85 over 40 millimeter mercury. Chest X-ray shows a large right hemothorax and a very small light apical pneumothorax, which is the first substance secreted in the process leading to increased renal absorption of sodium in response to the above injury. A, angiotensin-1, B, angiotensin-2, C, angiotensinogen, D, antidiuretic hormone, E, renin. Our answer is renin. Renin, the first hormone that acts on angiotensinogen.
This is the first step. He is asking here about the first substance secreted leading to increase renal reabsorption. It is angiotensin-1 will increase the absorption. Angiotensin-2, no. Angiotensinogen, no. Antidiuretic hormone, no.
The last.
Not the antidiuretic hormone. It will decrease the water secretions, but renin is the only one mechanism of action to make salt and water retention. This is the first substance that will cause salt and water retention. Okay. Next question.
During the second phase of wound healing, the predominant cell in the wound site are fibroblasts. The cell is of mesenchymal origin and produces the matrix and collagen needed to strengthen the scar. Cross-linkage of collagen requires hydroxyproline and hydroxylysine residues, which requires a specific vitamin to be available in sufficient quantities. Division of which of these vitamins results in collagen that is unstable. Our answer is vitamin C, ascorbic acid.
Okay, collagen stability, or which vitamin responsible for the collagen, for normal collagen in the body is vitamin C, ascorbic acid. Very common question. I don't know why they like vitamin C and so sometimes he tell you normal collagen, sometimes for cross linkage of collagen fibers or collagen proteins or cross linkage of collagen, and which is normal senses of collagen or normal collagen, whatever if he mentioned collagen in the exam and needs you to know what's your vitamin deficiency, it will be vitamin C. The other vitamins he like is the vitamin A, and he will tell you cloudy eyes, night blindness, and some sort of this one, cloudy eyes or night blindness. So he'll ask you about the vitamin, he will tell you vitamin A. And the other one is about patient has a neurological problems, and what is the most common vitamin responsible for these problems? You will answer, it will be thiamine or vitamin B1. Thiamine or vitamin B1 is responsible for the collagen, the neurological problems in the patient. Okay. Okay, Shabab, we did one. Resume record. Okay, continue, Dr. Ega.
Okay. A 62-year-old woman presents with a firm irregular mass in the upper outer quadrant of the right breast, which appears malignant on mammography. And fine needle aspiration cytology is reported as CA. Huh? That's CA. Which is the first lymph node to which
the
tumor is most likely to
is repeated.
Yeah, which is the first lymph node to which the tumor is most likely to metastasize to? That should be the sentinel lymph nodes. D.
Sentinel lymph nodes. First lymph node. Okay, this is the question. Is the first lymph node to the tumor test? This is sentinel lymph node. Okay, next question.
Which of the following statement is true with relation to cardiac muscles? A, the contraction does not involve release of calcium by the
okay, all of them are wrong sentence, so don't confuse yourself. I just want you to read the right answer. So in the exam, you will remember the right answer only.
Yeah, contraction is triggered by an influx of calcium through the sarcolemma. Influx of calcium.
Okay, contraction is triggered by influx of calcium through the sarcolemma. I just want you to know something and put something in your mind. When you find the question like, which of the following tests is true in relation to this? So read the only right answer, because don't confuse you by wrong answer, because he can change in the exam, because the wrong answer is blah blah blah. The wrong answer is blah blah blah. He don't use he can do, if he want to change something in the question, he will change it. Sodium calcium influx release pump nothing, he will do blah blah blah. He don't care about this one, but he will care about the right sentence. You have to read the right sentence, so in the exam you will know only the right sentence. The other question is, which of the following is wrong related to the cardiac muscle? You have to read all the right answers, because in the exam he can make it which one is true and get one of the right answers. So you know the 4 right, good, and the wrong answer, you will put it in your mind to exclude it. Because in the exam, if he try to make a new question in the exam, he just changed the scenario. He said, which one of the following is true about? And he get the 4 answers or 3 of the 4 answers and add it to the 1 wrong answer and make 4 wrong, and 1 by decreasing, make decrease, increase, shift, less than, more than, and so on. So which is true, read only the true. Which is false, read the whole question. Clear?
Clear.
Okay, yeah, continue.
A 70-year-old retired farm worker presents with a scaly lesion on the back of his left wrist. Biopsy shows enlarged pleomorphic squamous cells with mitosis that have breached the basement membrane. What is the name of this process? Because for this question, squamous cells that have, there's a breach already. If there is a breach, it's most likely in neoplasia.
Neoplasia. Scaly region back on the left wrist and biopsy showed enlarged pleomorphic squamous cell mitosis. Breach the basement membrane. خلاص. Breach the basement membrane. This is neoplasia. Dysplasia. There is no breach of the basement membrane.
Breach of the basement membrane.
Hyperplasia, no. Hypertrophinometaplasia, no. Neoplasia, there is breach of the basement membrane. Okay. Next question.
45-year-old man has established cirrhosis. At a follow-up appointment, a palpable spleen 4 finger breadth below the costal margin is noticed. Full blood counts have shown a persistent thrombocytopenia. Bone marrow examination shows a megakaryocyte hyperplasia. What is the most likely cause of thrombocytopenia? Okay, platelet destruction by the spleen.
Platelet destruction by the spleen. Okay, we have two important questions on the spleen. Okay, both of them are related to the platelet. So in our, we have a spleen destructive platelets. Okay.
Yes.
Enlarged spleen will destruct more platelets, so the patient will have thrombocytopenia. Splenectomy. Post-splenectomy blood picture. Yesterday we said what?
Thrombocytosis.
Thrombocytosis, because there is absence of the organs that destruct the platelets in the first few weeks. In the first few weeks of post-splenectomy, the patient will suffer from thrombocytosis, but patient has hypersplenism will suffer from thrombocytopenia. Clear, يا شباب?
Okay.
Okay, next question.
A surgeon is carrying out an elective splenectomy for congenital spherocytosis. Which structure will be divided in order to mobilize the spleen from the posterior abdominal wall? Okay. From the posterior abdominal wall, the lenorrheal ligament is the most posterior, while anteriorly is the gastrosplenic ligament.
Perfect. During splenectomy, I make exploration for the patient. Okay, I make exploration for the patient, and then I try to expose the spleen. Then I pull the fun. Who is here is general surgeon? Who is general surgeon? No one? No one is general surgeon? Oh, unfortunately. Okay. Okay, this is what you see during the exploration. This is what you see during the exploration. Just to make the stomach in front. What you do during the exploration, we open the abdomen and then we pull with hand, we pull down the fundus of the stomach with the left hand, with the right hand, and then we clamp the gastrosplenic ligament by 2 clamps and cut it. And this is the most anterior structure you have to divide to reach the hilum of the spleen. Exactly here. We open here exploration, and then pull this stomach, and then clamp 2 clamps here, and then cut here. So if he told you what is the most anterior structure we have to divide to reach the hilum of the spleen, it will be the gastrosplenic ligament. Gastrosplenic ligament. After you cut this, you will open the lesser sac. This is the lesser sac here. So I open, so I pull the stomach down. I pull the stomach down. I hold the spleen here, and I cut this edge. And I found here the splenic hilum going to the spleen within the lienorenal ligament. And this is behind the stomach here. This is all the lesser sac behind the stomach. This is the lesser sac. What is this? This one. So I cut it this, and I open the lesser sac. I pull the stomach away from me so I can see the pancreas, the tail of the pancreas, and the splenic artery, and the spleen going to the hilum of the spleen. And then I go direct to like clamp the splenic hilum very close to the spleen, not to injure the tail of the pancreas, to ligate and cut the posterior ligament, which is the lienorenal ligament. So we have some questions here. One question: what is the first ligament you will divide to reach the hilum of the stomach? It will be gastrosplenic ligament, containing
the
short gastric vessel. First anterior to divide to reach the hilum of the stomach is the gastrosplenic ligament, containing short gastric vessels. Okay, then what is the ligament you will divide to mobilize the spleen from the posterior abdominal wall? Second is anterior. This posterior is the lienorenal ligament, containing the
splenic vessels.
Splenic artery and
vein.
tail of pancreas. Splenic vessels and tail of pancreas. Tail of pancreas. Short gastric vessels close to fundus of the stomach. Fundus of the stomach. Okay. So if I am cutting the gastrosplenic ligament, what is the most common injury that I can make? Fundus of the stomach. Fundus of the stomach. If I am cutting the short gastric vessels here through the gastrosplenic ligament, I can injury and make hematoma to this. By the way, this is very common to happen in with unexpert surgeon doing emergency splenectomy and trying to put clamps. When hematoma happens, by the way, this area all is full of hematoma, and he can't see where to put the clamps to stop bleeding, and he can injure the wall of the stomach, especially the fundus, sometimes the greater curvature, but mainly the fundus. Clear? Oh, if I am in emergency situation and am I ligating the hilum of the stomach after I ligate the gastrosplenic ligament and I cut it and open and retracted the stomach, and I'm trying to clamp and cut and divide the hilum of the spleen, I'll clamp and cut the lienorenal ligament. What is the most common injuries that happen? Tail of pancreas. That's why we tell you patient post-splenectomy has a high amylase level and drain serous discharge from the wound. This will be pancreatic injury during cutting off lienorenal ligament. This question, January 2021, September 2020, January 2020. Asking about the lienorenal ligament and the gastrosplenic ligament and what is the structure injured during ligation of every one. Okay.
Okay. Dr. Ram, if there is an injury to the tail of the pancreas, what?
If what?
If there's injury to the tail of the pancreas, what's the next best step to remove the tail of the pancreas?
If there is injury of the tail of the pancreas?
Yes.
Okay, it is not it is out of your scope, but normally this has a duct. You have to ligate to suture because you open the duct. That's why in doing pancreatectomy we're using a stapler because it has ducts, open ducts. Fasciculations will go. So a stapler, you will do a stapler to suture the cut end, like distal pancreatectomy and so on. And patients confirming from insulinoma. Sometimes we do blind distal pancreatectomy.
Okay.
Okay. Continue. Who can continue?
A 50-year-old man is admitted with epigastric pain and a rigid abdomen. He is diagnosed with perforated duodenal ulcer. Ulceration due to excessive gastric activity may be caused by increased level of which one of the following? Adrenaline, calcitonin, glucagon, secretin, and somatostatin. Our answer is adrenaline, epinephrine.
Okay. As we said before, high gastrin level will cause recurrent resistant gastric ulceration. Okay. Sometimes due to gastrinoma, yes, and sometimes due to other causes like patient has high epinephrine or adrenaline level. You know, stress ulcers?
Yes.
Patient who has always under stress, patient who's under stress has a high adrenal and epinephrine level. That's why they have recurrent peptic ulceration.
Okay. Stressful.
Smokers and always under stress and nervous patient and patient with very bad mood all the time. This patient has a high level of adrenaline and epinephrine. So that's why these patients always have stress ulcers because of this. So remember that adrenaline patient, nervous patient have always high epinephrine or adrenaline level. So increase the gastrin level, so increase the gastric ulceration. Okay.
Thank you.
Just to remember this. Okay, clean. Next question.
A 66-year-old woman with tumor of her spine has started to retain urine and is experiencing decreased ana and rectal. The tumor is pressing directly to the conus medullaris. At which one of the following vertebral levels is the tumor most likely to be located? For an adult, the caudal equina is located at L1. So that explains CL1, L2 level. For an infant, it's located, conus medullaris is located more distally, which is at L3.
Okay, the tumor is compressing directly on the conus medullaris. What is the level of the conus medullaris?
L1.
L1, L2. Conus medullaris is the end of the spinal cord. Here is this scenario. He is indirectly asking you what is the level of the conus medullaris in adults. Very simple. L1, L2. Okay, simply L1, L2. Okay, and that's why he said the experience decrease the anal and rectal tone because this is a lower motor neuron lesion. If it is a high motor neuron lesion in the spinal cord above this level, it can cause increased tonicity of the anal and rectum, and also the cystic, the urinary bladder. The patient will have urinary retention, but this is because it is compressing directly on the nerve, so the patient suffered from decreased anal and rectal tone. But here, simple. What is the level of the conus medullaris in adult? L1, L2. Next question.
Yeah. A 26-year-old man presents with a 2-month history of unilateral testicular swelling. An ultrasound scan shows a heterogeneous mass with the testis with surrounding fluid. His blood test shows an elevated alpha-fetoprotein. Which of the following is the most likely diagnosis? Yes, 20 teratoma.
20 teratoma. 20 teratoma. Plus 20 teratoma. Forget about this. 20s, always in this, keep in your mind in part A and part B. If you want you to diagnose teratoma, he will give you patient in 20s. Okay. Next question.
A 50-year-old woman presents with a history of fecal incontinence over the past few years. She had a prolonged and difficult first stage labor 20 years previously. Physical examination reveals a relatively lax anal sphincter. Which nerve is likely to have been damaged in labor? This is most likely the pudendal nerve, which prevents stool and urine from the floor.
Okay. What is the nerve? What is the root value of pudendal nerve?
S2, S3, and S4.
S2, 3, 4 keeps support outside the floor, away from the floor. S2, 3, 4. Very common to ask you about this question in the exam. Next question.
A 70-year-old man is admitted to the hospital with a 12-hour history of painful white leg. Femoral artery embolus is shown on an angiography. He is an insulin-controlled diabetic and takes ibuprofen for long-standing osteoarthritis. 24 hours after emergency embolectomy, his blood pressure is 90/60, and he passes very dark brown urine. A dipstick shows myoglobin and traces of blood. His blood glucose is 15 millimole per liter, which is high. His urea is 12 millimole per liter, which is also high, and creatinine 180 millimole per liter, which is high, which suggests some kidney injury. What is the most likely cause of his abnormal renal function? Okay. Patient is suffering, because of myoglobin injury to the myoglobin causes injury to the kidneys and increased myoglobin from muscles. Patients, because they are saying that there's already a white leg, so there's already some form of rhabdomyolysis.
Rhabdomyolysis, okay. Myoglobin in your MRCS part A or part B equals rhabdomyolysis. Myoglobin in urine in part A and part B, you have nothing to think about except for rhabdomyolysis and renal injury. Okay?
Okay.
Don't forget about anything. Once you see myoglobin in the question, go direct and search for rhabdomyolysis. If you found it, you are 100% right. Dr. Amina, can you continue the last 5 questions, please? We want no, I don't want all the others to sleep. Last 5 questions, please, if you can.
Okay. An 86-year-old woman with a history of partial gastrectomy is in the high dependency unit for chest infection that is being treated with antibiotics. She complains of difficulty swallowing. Endoscopy shows multiple white plaques on the mucosal surface of the esophagus. Biopsy is most likely to show. This patient is on antibiotics and white plaques. This is a feature of candidiasis, most probably.
Okay.
So the answer is C.
Okay. Old patient, partial gastrectomy, the patient has chest infection, antibiotics, so the patient have low immunity, and this is very common for opportunistic organisms like Candida to invade his esophagus. Okay, this is Candida esophagitis.
A 65-year-old woman has been given a total of 15 milligrams of morphine over a 30-minute period for pain relief following a femoral neck fracture. Mellowing observations are found. Saturation of oxygen on 80% is 80. Blood pressure is 90/60. Respiratory rate is 6. The immediate intervention would be, since her respiratory rate is very low, and
Yes.
this is like an emergency, we'd have to go straight for tracheal intubation.
Okay, forget about this drug antidote because this question was first answered as intravenous naloxone. So you have to go for this patient with ABC, airway, breathing rate is 6. So you have to give an airway for this patient. So you have to start with tracheal intubation, then start to give the antidote. This question for a long time is answered intravenous naloxone. Okay, but I got the indication for intubation to be, it will be heart rate of 6 or less. This is one of the indication of intubation. So this patient, if you manage this patient due to trauma protocol, ABC, airway, breathing, circulation, when you go for the breathing, as you found the patient has decreased respiratory rate, you have to start your breathing aid through intubation and giving external breathing for this patient. Next question.
The following drugs are used to treat patients with peripheral vascular disease. They all reduce the rate of myocardial infarction and stroke except oxyphentylphenidate.
No problem. Just know this as it is. Never came before, but know it. May it come like this, so it will come once, it come many times. So just know it. By the way, just if you know that any patient with peripheral vascular disease, this is a drug modifying agents and lifestyle modifying agent. And this is the drugs we give for any patient having peripheral vascular disease. We give him ACE inhibitors, we give him something to decrease blood pressure, give him something for diabetes, we give him aspirin, and we give him something for dyslipidemia. These are very common, by the way, combination we give for patients with peripheral vascular disease, but we didn't hear about bronchodilator or beta-2 blocker. This is mostly beta-2 blocker to give it for a patient with peripheral vascular disease. Okay.
Okay. A 4-year-old boy is brought to the emergency department with painful right elbow. His father states that he was swinging his son by his arm when the pain came on suddenly. An X-ray shows that the radial head is displaced from its usual position. What is the ligament of the proximal radioulnar joint that holds the radial head in place. That is the annular ligament.
Okay, this is an MRCS question.
Yes.
Last question.
A 35-year-old man presents with a 3-week history of low back pain and a 3-day history of pain and weakness in his left leg. Physical examination demonstrates numbness over the posterior aspect of the left calf extending to the lateral aspect of the foot. Left ankle reflex is absent. A magnetic resonance scan shows compression of the left S1 nerve root. What is the most likely responsible structure? And that is the nucleus pulposus. Compression
Nucleus
by the nucleus.
pulposus. Okay, nucleus pulposus, which is bulge from the annulus fibrosus and causes compression on the nerve. Okay,
Exactly.
the nucleus pulposus, not the annular fibrosis. Okay, thank you. We finished Fawzia sheet paper 1.
Yes.
Okay.